It's my pleasure to introduce Dr. Judith Rappoport, who will be speaking to us this morning. Please, if I could have your attention. Dr. Rappaport is a graduate of Swarthmore College and Harvard Medical School. She completed her clinical and research training at the Massachusetts Mental Health Center at the Children's Hospital in Washington, D.C., as well as the Karolinska Institute in Stockholm. Since 1984, she's been the chief of the Child Psychiatry branch in the intramural program at the National Institutes of Mental Health. And in that role, she has led literally generations of investigators exploring the phenomenology, the neurobiology, and the treatment of childhood onset schizophrenia, which she'll be speaking about this morning, but also obsessive compulsive disorder and attention deficit hyperactivity disorder. She and her team of investigators have made critical discoveries with regard to brain development, both in individuals in terms of their normal development, at-risk populations, as well as individuals with these disorders. She's also pioneered the use of medication, psychopharmacology, in the treatment of these conditions. Not surprisingly, she's received numerous honors. She's a member of the Institute of Medicine. She received the Ruane Prize from a prominent advocacy organization in the United States, NARSAD. And she's internationally known for her book on OCD, The Boy Who Could Not Stop Washing. She's the author of more than 500 scientific articles, Science, Nature, Proceedings of the National Academy of Sciences, innumerable articles in our major journals, Archives of General Psychiatry, the American Journal of Psychiatry, and I think most importantly has been a prominent mentor. I think of Henrietta Leonard, who just recently has passed away, Sue Sweeto, Javier Castellanos, Jay Geed, Rob Nicholson, to name just a few. And one of the Cohen Fellows, Tom Fernandez, began his research career actually as a research assistant in Judy's team. So without any further ado, I would like to introduce Judy, a real friend, someone I admire, and please, Judy. So I think this is just advancing.
Thank you very much, Jim. And I'd like to thank Professor Caffo and ESCAP for the great honor of speaking here and giving one of the opening addresses at this remarkable Congress. I'm very impressed at how many people have come here to learn about research, clinical work, and of course to enjoy Florence, which we have all been doing. It's very unusual for someone in child psychiatry to be talking about schizophrenia, but I think, therefore, that it is perhaps useful to say something about why I got into this topic, because the majority of you, I'm sure, in your life as child and adolescent psychiatrists, very rarely see someone with this diagnosis. But there are several reasons why you would want to study a rare population, and I will try to explain how I got into this. Then I want to tell you a little bit about this group, now that it is 15 years later, and my group has studied more than 100 children with schizophrenia. I want to convince you that it's the same disorder as what the adult psychiatrists see, and why it was worth doing this. Because sometimes very early onset disorder teaches you something very special. So I hope you can follow this, and although there's no official question period after this address, I'll be happy to try to explain or talk to people later at various times during the Congress. So this is a overall slide that shows how very complicated it is to think about schizophrenia, although I might say this might hold for anybody, for anything, because of course this slide talks about prenatal complications, it talks about social events, it talks about the whole period of development, and things can go wrong at any time. But highlighted in red, the reason why you study a very early onset is because you hope some aspects of the disorder will become much more clear or striking when you study an extreme population. And highlighted in red is the genetics, issues of brain development, and some of the earlier developmental facts, which were things that just leapt out with us as we started to study childhood schizophrenia. And in fact, I was inspired in part by a quote from long ago from Franz Kallmann, one of the great early psychiatric geneticists, who said that since most schizophrenia starts after adolescence, that there must be some important factors or combinations of factors that lets this happen at a very unusually early disease. And I might say this has paid off for me. We learned a lot about obsessive-compulsive disorder from studying children with obsessive-compulsive disorder first. This is just an example from genetics in Crohn's disease, regional ileitis. And in Crohn's disease, usually this starts somewhat later in life, but it can start in childhood. And this is just what's called a LOD score, which is the strength of effect of a candidate gene. And the people studying it in adults were very controversial about whether this particular gene was significant. But once they picked early onset cases, it got very clear in Crohn's disease that this was an important gene in the disorder. And in general, there have been many review articles on this, but in general, you supposedly have fewer genes, more affected relatives, less effective social situations in very early presentations of many, many illnesses across all of medicine and biology. So there had been some early descriptions of somewhat smaller, and the first clue we got as we started to advertise for cases and select them, our very first clue was that the people who had looked at smaller numbers of children with so-called schizophrenia, they noticed that they had had all sorts of problems early on. They had speech delay, some of them had had social and motor problems, some of them had even been diagnosed as pervasive developmental disorder. And I don't want you to be confused. I agree with the very great deal of work by Professor Michael Rudder that autism and schizophrenia are very clearly distinct disorders. But then when you get into the question of, well, what was the early history of childhood schizophrenia, then you notice that a lot of those kinds of delays were very common in their early years. And another interesting fact, and that is that this is the sex ratio. Admissions, and this happens to be in England, but there's the same data for Germany and for France. This is just the rate of admissions to hospital for schizophrenia. And as you know, it's very higher in early adulthood and much higher rate, or somewhat higher rate, in males than females. But once you get down to this very, very early age, and we only took patients for our study, that's why it took us 15 years to get our population, who had the psychotic symptoms before they became 13. Once you get down here, you don't even have the sex ratio anymore. There's something else that seems to be stronger, and it's not so strongly more male. So we've been looking for these cases. It's been a great deal of work. We've done this along with other things while we got these cases. But by now we have had very many referrals, and we have interviewed the ones that truly had an IQ that was in the normal range, and we would bring children in to be screened in person. And we finally have had our population that were admitted as schizophrenia. And I might add that even of the ones we admitted as schizophrenia, who seemed very clear from the history, we had the privilege of being able to observe these children for 2 weeks without any medication at all. And even then, you see some children who turn out to be classically bipolar, who on medication seem fine. And that's both a good thing and a bad thing. It's very good clinically that some of the antipsychotics are so effective in bipolar disorder, but it's a bad thing for a researcher because it means that you absolutely need to see people for some weeks without medication to be sure of the diagnosis, and that is, for many people, a very challenging and difficult thing to do. And so this is just to say that very understandably, when you have a rare disorder, many of the people who we see who come to us with the diagnosis of schizophrenia have something else. Of course, many really have schizophrenia, but others have either extreme behavior disorders. I mentioned bipolar disorder, psychotic depression, and all sorts of other disorders that are so severe that people are convinced that it must be psychosis. This is not any insult to child psychiatry. When we first started studying obsessive-compulsive disorder many years ago, people saw so few cases that most of the referrals we got were something else. This just has to do with getting to know something and getting used to how it presents. And our sample had a mean age when we first met them of 14, but the onset of psychosis was age 10. And the main point of this slide is to say that the great majority of these children had been seen several years before because of earlier developmental problems. So they were not new to the system, and most of them had had drugs for a few years because, at least in the United States, low-dose risperidone is used very widely for behavioral problems in child psychiatry, even when it's an off-label indication. And this is, again, just to say that of the children who later turn out to be schizophrenia, that this is a Venn diagram to say that there's relatively few that did not have an early history of either social or language or motor problems. So you should expect that, and expect to have some of these children having had an earlier diagnosis of pervasive developmental disorder. This one could spend the entire lecture about that and say, is some kind of PDD a risk for schizophrenia? But I think this is of much more theoretical interest because all of our cases had classic DSM-defined schizophrenia. The diagnosis was not modified in any way. This is just says the same thing, except to say that even after clozapine had a very good effect and took care of all of the psychotic symptoms, almost a third of our sample, if you were to interview them, would still meet some criteria for pervasive developmental disorder. And so I think there's some general impairment of early brain development, which is important for early onset schizophrenia, and which overlaps in the symptoms with PDD. Now, at first, the people in the adult field of schizophrenia were very skeptical, and so we had some years of studies to convince them that we're really studying the same thing. And of course, by clinical presentation, of course we were studying the same thing because that's how we defined what we were going to study. And premorbid function turned out to be the same thing because there have been many large, what they call cohort studies in adult schizophrenia, in which they show that at a subtle level, patients compared to their brothers or sisters or the normal population tend to speak a few months late, to walk a few months late, perhaps to have some stud problems in socialization. And so this too was like an exaggeration. It was something that was more so than you see with adults. We've done neuropsychological studies to show that some of the same kinds of short-term memory, working memory problems, some of the same kinds of changing some kinds of cognitive rigidity were very much similar to that was seen in adults. Studies of autonomic reactivity, of family studies, of smooth pursuit eye movements, anatomic brain studies, which I will talk about in a minute, all look like it was the same disorder. Now it isn't a problem anymore, but when you talk to the typical adult psychiatrists who study schizophrenia, they were very puzzled they tended not to have seen this in childhood and were very puzzled about it. And then we tried looking at the prenatal events, and that was to narrow down where we would find things that were interesting with this population. So we collected every single piece of paper ever provided for these children, and we got all of the birth records for all of our patients and the birth records for all of their siblings. And with colleagues at Columbia, we showed that in fact there was no excess of prenatal events, no problems for what clinical records were worth. And we did show, however, and then there was another question, well, maybe these children just have early puberty, but we got all their pediatric records, and their puberty was just at the quite normal age, so it wasn't as if they were advanced sexually in their development. That was not the answer. But a whole bunch of things started to come up positive. First of all, we sent blood on all of our cases for cytogenetics, just rearrangements of the chromosomes. And it turned out, as I'll show in a minute, that they have not only a high rate, but a relative to controls, but much higher compared to the adult group. I've mentioned premorbid development. We did have interviews with all of their first-degree relatives that we compared to the first-degree relatives of controls and of adult patients, and they seemed to have a slightly higher rate of family schizophrenia and spectrum disorders, and some evidence of abnormal eye movements in the family. So we've started to see some sense of what the risk factors were, and they started to look at cytogenetics and genetics in the family. This is just an example of what the data would look like, and these are ratings that were scored blind of schizophrenia spectrum disorder. And what we see here is that these are our childhood cases, and that there's a higher rate, although less than a quarter, with schizophrenia spectrum disorder, these avoidant or schizoid personality and so on, or schizoaffective disorder. And then in the adult patients higher, and the control families very low. Nevertheless, just like in adult schizophrenia, our typical child has no relative that has schizophrenia, and this isn't something so clinically obvious. But to a researcher, this was very interesting, because this was something more so than for the adults. As many of you probably know, one of the things we've been privileged to do during our years at the NIH, which has a remarkable place with very stable funding for people to study difficult things to study under other circumstances. And so we've been able to study this group of children from childhood through into their adult years. And my personal prejudice is that as a child psychiatrist, one of the most fascinating things our entire profession can do is long-term follow-ups. It's among the most things useful clinically, and the most things, I think, theoretically in many cases. So we were able to do scans, brain scans on these children at different times across their whole development. And just with this and so we could compare them against controls, and then 5 years, 10 years, now 15 years later, we could compare their brain scans against those of the same controls. And perhaps the most striking thing that we noticed early in our study was that, yes, early in the study, we have a difference, and where it's red, means that when you subtract the scans, and these are anatomic scans, not functional scans, but when you subtract them from the control group, what you see is a difference, and this is the front of the brain, and this is the back. It looks like it's mostly in the back of the brain. And this is just the left side, the top, left side, the right side, and the top. But 5 years later, with the same subjects and the same controls, it's like it is spread all the way forward. So perhaps one of the most interesting things that we found, which we didn't expect to find, was that in spite of the fact that schizophrenia had been considered some fixed lesion that you have, and then you get schizophrenia through what happens as the brain develops, even when we were seeing these patients, we were seeing the brains are changing. And we've followed these cases now. To go back 1 minute, what was a puzzle about this isn't how adults look. Typically, when you do adult studies, what you do is you see an area perhaps there that's different and an area there that's different, but it doesn't look like it's so completely different compared to controls. But when you follow these cases, and you should look at this though, just to see which parts of the brain by age 24 are different compared to adults, we see that by the time these children are adults, as some of ours are since our study's been going on for 15 years, this is just the kind of finding you would have in adults. And that in fact, it suggests that most of the changes in the brain, when you do see a patient with schizophrenia, if it's a child, a lot of them are happening now. But that when you see an adult, all of the changes probably were happening in the years before anybody met them. And that's a very intriguing idea, because increasingly people are looking at targets for study, targets for drug treatment, targets perhaps for other kinds of treatment. And it suggests that this brain progression may be a candidate as a target for treatment in future research studies. What is very interesting is, well, how does this happen? Remember, in the early pictures, the brain looks abnormal everywhere, and then in the later pictures, the abnormality was only in a few areas. And so what we've been studying is that you can see here, this is just a lot of scatter of what the data looks like, but this is for healthy controls. What happens is, as the brain develops, the gray matter, the cortex, typically produces too much matter, and then later in adolescence it goes down. It's an inverted U. And at the age when we're studying these children, it's mostly already going down. So what all of these very hard to see pictures really resemble are the red dots are the healthy controls in which is normal, losing some gray matter, probably synapses, and their cortex getting more normal. But the blue, which are the patients, actually, in some of these areas that get better, are actually inhibiting this process. So this is perhaps very complicated to be showing in such a large group. The point to get across is it looks as if the patients can inhibit the loss compared to the controls, so that the controls catch up, and as a result parts of the brain can look a lot more normal. Now this is way beyond the topic of this talk, which is just about our findings with the schizophrenia in children, but I might add that some of the most interesting findings that we're getting now in hyperactivity and ADHD is also showing that for the ones who get better, it looks like parts of the brain, they inhibit this loss, and that perhaps because other parts of the brain are able to take over. And I think that's where brain imaging is particularly interesting, in showing plasticity and what the brain does to try to repair itself or make things work a different way. This is just to mention, because I feel I shouldn't, at least nod, the National Institute of Mental Health has done a comparison treatment of different antipsychotics. And I feel I should mention this mostly because I work at the National Institute of Mental Health, but I'm not talking particularly about treatment, but there are starting to be large treatment trials that have compared molindone, which is a first-generation antipsychotic, with olanzapine and risperidone, and that this is a treatment of early-onset schizophrenia, these are studies in which they had predicted that the atypical agents would be better, and molindone was chosen because it has less weight gain. And as I say, there are many other better studies on treatment that are taking place throughout the course of this meeting. But because very few focus on psychosis, I thought that I would just mention that this study did manage to find this many patients, and this included some adolescent onset, and that the bottom line really was that all of the drugs had significant reduction in symptoms, but that the first generation drug seemed pretty much as good as the others, and that the side effects were not more adverse, and in fact things favored the first generation drug somewhat, which was as good as the comparison drugs. And there are people at NIMH here at this meeting who are much better prepared to discuss this, but I don't want to suggest that treatment is being neglected entirely. And in fact, in our own group, when the children really don't respond well to any of the other antipsychotics, we have also shown that clozapine can work when everything else has not worked for some of these children. This is a very, very ill group, and I've put this in somewhat disruptively to my own talk because what I want to focus on more has been the neuroscience that has come out of this project. But this is really to make the point that we've been worrying very much about what kind of treatments may help. And we continue to try new treatments for this group that even when they do respond to a drug, they often have quite a few symptoms that remain, even if the drug helps somewhat. So it won't surprise anybody that we looked at genes, and I'm going to spend the rest of my talk about how things are looking with respect to the genetics of schizophrenia, because really what inspired our talk was what was happening when we started in genetics in general. We saw that there were breakthroughs with breast cancer because of studying very early onset cases, that what looked like a very messy group of studies with aging, with Alzheimer's disease, got much more clear when they stratified their groups by age. And so we persisted in getting this group largely because we were interested in what some of the genetic studies would look like. Well, with respect to just looking at candidate genes, we did, in fact, with a relatively small group, take some of the best replicated genes in adult schizophrenia. And if it's a color next to it, it means that we were able to, by doing analyses within the family, comparing the rates of getting the so-called risk alleles for the patient compared with their siblings, or compared with, is it greater than chance that they get this allele from their families, we do have a signal for this. And we had a control group of genes, ones that had been claimed to be positive in autism, and none of the ones that were claimed positive in autism looked like they were interesting for this group, but at least 5 of the ones that have been positive for schizophrenia were. So we take this as a hint that probably, again, it must be the same disorder. But our numbers are so small for our group that you could argue maybe these genes are a little bit stronger, because it's hard to find a signal diagnostically when you have such a small, for geneticists now, they are tending to use closer to 1,000 subjects in a genetic study, not just such a small number of this. And of course that's very nice to have a positive finding, and we had no trouble publishing this, but wasn't what was so striking. We weren't prepared for what was really going to be different about our group. This is just to say that, to go back for a minute, that each of these positive genes had interesting correlations of who were the ones who had these genes that made it even more convincing that one of these genes seemed to be with our later age of onset, and that one is related to a particular pattern of cortical gray loss. And one of these had a lot to do with the premorbid adjustment, and one related to, again, social withdrawal and IQ, one delayed social and language, and those are the same kinds of correlations that are seen in the adult studies. So we truly believed it. It wasn't as if every gene had the same kinds of correlations. And this was just to mention one of the genes that we found that is expressed lower in the postmortem brain, and that this is a gene that it affects the rate of which the gray matter is being lost in adolescence. And so we were starting to build a system of using the developmental trajectory of the brain and showing that the genes have an effect on that loss of brain matter that I was showing you during adolescence. And here is the effect. This is a plot with age of gray matter volume, and this is just showing that if you have the risk allele, you seem to be losing it relative to the schizophrenic subjects without the risk allele. And that, interestingly enough, in the healthy controls, you don't get that much of an effect. So it looks as if the effects on the brain of some of these genes are very different how it affects development depending on your diagnosis, and it isn't anything so simple. And probably the genes must be acting in relation to other genes. So this is a whole other area of how you infer gene action by its effect on the brain trajectories. And similarly in white matter, you can get very different effects on the brain development for the schizophrenia group than from the control group. And again, the exact details are not so important, just to realize how complicated it's going to be, this neurobiology, because even if you can find an effect, it's probably not the same effect of the gene in the patients that it is in healthy controls. And so, and that's not always the case, because in ADHD, some of our risk genes for ADHD, it looks like they do have the same effect on the brains in ADHD as controls, and it looks much more like it's a continuum across healthy behavior and illness behavior. So we were very reassured that several of the candidate genes were the same as for the adult disorder. Again, for us that means, yes, we're probably really studying the same disorder. But let's get on to where we were really surprised, which was chromosomal aberrations and rearrangements. This is an incomplete list because the list keeps growing, but one of the indications for getting cytogenetic testing is an unusual presentation of psychosis, and childhood is a very unusual presentation of psychosis. And so, of course, we sent samples, fresh blood samples, to the very excellent cytogenetics lab we work with for cytogenetic testing. And they were calling us up quite regularly. This is only 9 patients, but there were already several others that didn't make it onto the list. We found 4 cases with a syndrome of VCFS, and this is the ventricular cardofacial syndrome, or DeGeorge syndrome. 3 cases of X chromosome abnormalities, Turner's syndrome, which means you're missing part or all of an X chromosome, and a case of 3 X's, 1 balanced translocation, 1 has a chunk of a chromosome where both parts, the end of the chromosome, both parts come from one parent. We have another child where there is an extra piece a very large extra piece that seems to be stuck from chromosome 1 that's stuck onto another chromosome, and so on. And so it looks as if there's a very high rate of these different kind of chromosomal abnormalities. Some of them I'll just mention briefly, but this is a real mixture. And I want to say that in adult schizophrenia, these have been reported as being somewhat elevated. It's just that in childhood schizophrenia, it seems like this is much more so, okay? So, for example, in these children, these are children who, if you look closely, you can perhaps notice that they have a small mouth or a bulbous tip on their nose, but it's not obvious. When they walk in a room, no one thinks this is a very funny-looking child. It's not obvious that way. And as I say, we have quite a high rate in our cases. It had been reported as high in a number of studies in adult schizophrenia, but it's much, much higher, the rate for our cases. And there are a lot of interesting genes within that region, but for reasons which I will show you in a moment, we don't know if the problem has anything to do with that region or not. And it may be a much more general kind of problem with just chromosomes that behave badly, that lose pieces, that tend to break at a very small level, that is the problem in childhood schizophrenia. Turner syndrome is another very interesting thing. It's been Turner syndrome. I'm assuming that everyone here knows what Turner syndrome is. It's designed, what most people think of it is a syndrome where you're missing all of one X. It's, of course, only seen in females. It's an XO. But in fact, many what they call Turner syndrome include you can just be missing a small part of an X, or you can have what's so-called mosaic Turners, in which not all of the cells of your body have this problem. And the rate is, it's not so rare. In females, it's about 0.04%, and in adults, it's been described as 0.17%, and we're seeing it in about 5% of the females. But we came on a clue that I think is one of the most interesting things in terms of the genetics of schizophrenia, and that is when you look in the literature for cases with Turners that have been reported in schizophrenia, all but one of them is mosaic. They didn't know that they had Turners. They had very mild kinds of Turners. Some of them had been able to have children. Many of them had no idea they were different, and it was only when they were screened as part of a large population of female schizophrenics did anyone know they had this problem. And so that's a clue that I'll come back to, but keep that in mind. And so I say all of these are different ways of presenting of being Turners. And so because ours were very uncommon forms of Turners, what was been proposed is that that's just a red flag, having Turners, that your chromosomes are likely to have instabilities in them. And in fact, we found a wonderful quote from 1968 of the two physicians whom I had never heard of, who had been studying very large hospitals of patients with Turner syndrome. And what they noticed at the time was that since the females show a high incidence of these different sex chromosome aneuploidies, particularly mosaicism, which means not in all the cells, and the cases, as I say, were very mild. You would never pick them up as Turner syndrome. They didn't have the symptoms. He suggested that subtle genetic instabilities must be associated with schizophrenia. And so, as I say, the likelihood of our patients being by chance are less than 1 in 1,200. So given that, which is now to catch you up to date, given that observation that we had reason to think that this is a group with very unstable chromosomes, we wanted to take advantage of new techniques in genetics, of doing whole genome scans, where you have the ability now to look at what's called copy number variations, or CNVs. And CNVs has now become the hot word in genetics, and there's certainly in autism and in bipolar disorder, in almost every disorder. It is starting to be the subject for a new way of looking at all of the genes without thinking in terms of a particular one. And this is still such a new technique that I show you this slide to show how hard it is. These are different colors showing different techniques for looking at copy number variations across the genome. And this is so new that in the few studies that have had them all look at the same population, they hardly agree with each other. So although I'm very excited about the data I'm about to show you, it's very important to know that this technology is so new that you spend, 1 year getting the data and then at least another year trying to validate it. But our hypothesis was that the children with schizophrenia would have a lot of these unstable, subtle abnormalities in their genome. And so we used 3 different whole genome scans because I just showed you a slide, they don't agree with each other. And these are different arrays, a 500 Affymetrix chip, a method called CGH. We also looked at expression in all of these families, which I don't think I'm going to get into. And we also looked at other kinds of ways of looking for abnormalities each of these provide a great deal of data that we will be spending the next at least year and a half analyzing. But I want to leave you with what I think are some suggestions that this may be the most interesting, if puzzling, finding that we have so far today. And as I say, looking at little duplications and deletions has been something that recently, in Nature Genetics, there have been a whole series of very interesting findings that if you take children with mental retardation, you're going to find that, up to 10% of the children are going to have a higher rate of these duplications and deletions that all seem quite rare. And again, I think in terms of the time, I won't get into the fact that we do have agreement across some of these, an expression agreeing with some of them. Why don't we just start with this? This is ones in which we are looking at events that are deletions or duplications in the children compared to their siblings. And one of the first things we found was that children were a little bit higher in general, but we have a bunch that are very extreme here that have a higher number than any of their siblings. And when we look at this, we find that we have a whole group of actually 4 children that have duplications in the middle of a gene called DISC1, which is a very well-known risk gene for schizophrenia. And another new gene active in the brain that again has 4. So you look not just for duplications, but are they in a region where the brain is active? So that was very exciting. But that's not quite the same as just the whole genome scan. Except that for the DISC1, this is a gene that was found from a pedigree where there was a large rate of schizophrenia. And our duplication that our 4 cases have is right near where the initial report of what was wrong with this gene had. So it looks like this is a technique that's likely to pay off in a lot of interesting ways. And we have another patient where there was a lot of illness in the family, and we have a duplication in another gene that looks like it tracks. This is not the same as a risk allele. This is chromosomal instability, where there's just a small amount of extra material duplicated or deleted. But what I want to leave is that if you just look at these deletions that none of the parents had, so they're de novo deletions, they're rare, almost no 2 are the same, what we see is that compared to the healthy siblings, that the patients have more of these. And what's more, this is now looks at the size of the deletion and this is the patients, and this is their healthy siblings. And I think that in the interest of time, I think I'm not going to say very much more than this, that it looks like if you look at very small deletions in a very small area, under 100 kb, for those of you who ever think in terms of genetic information, it looks as if twice as many of these patients compared to the controls are having these very small deletions in the chromosome. Well, what does this mean? First of all, they all turn out to be rare. They're almost no two the same. And what this is going to, in some ways, make sense because it's so hard to find out dreams of very strong effect. And there is a group on the West Coast that has just done something like this in adult patients who thinks that they may have some kind of similar finding. But I think that the genetics of schizophrenia is going to be as complicated as something like this, and that what we hope to do in the future will be find pathways of what this means based on where these deletions are, and see if they will give us some clue to disease based on these pathways, rather than finding any one single gene where this is going to make a lot of sense. So as I say, the genetics, I think, is going to pay off with this very, very early onset group. And I'm going to hurry through. The Dr. Kaplan from 1968 was right. If you're a patient with schizophrenia that has a cytogenetic abnormality, you are much more likely to have other abnormalities all over the genome. So perhaps these sex chromosome and the VCFS are important, not just because of whatever that is, but because it's a sign that you have a specially unstable set of chromosomes. And I'm going to just not talk about the gene expression, but just get to the end by saying another possibility of this whole study is that we're not so much studying schizophrenia as something unique to age of onset. Because if you do twin studies where everybody is schizophrenic, and you're just looking at age of onset, the identical twins have a much stronger likelihood of having the same age of onset than the fraternal twins. And so there may be an age of onset effect here, which in itself could be as important as anything else. Because what we would like to see come out of this study would be to be able to say, well, there is this diagnosis, but perhaps we know something to change what age you get it and make this happen many years later. And that would be a wonderful goal for a project like this. I think I will stop here and just thank my collaborators and thank you for your attention.